And then we'll proceed to our next speaker.
Next speaker is Dr. Abburi Ramaiah, and he's going to talk about combinatorial therapy with basic fibroblast growth factor related Agonist Peptide to treat vitiligo. And he's a professor of biochemistry at Indian Institute of Medical Science in New Delhi.
Thank you very much. At the outset, I'd like to thank the organizers of this symposium who accepted my abstract for oral presentation. I'm very grateful for that, to have this opportunity to talk to you all. The topic, as mentioned, combinatorial therapies with basic fibroblast growth factor related agonist peptides to treat vitiligo. After all, we have been listening all the causative agents that produce the disease. I have only listed them, all of them, but I like to say all the above theories are intertwined. They're not alone doing the job. Maybe all of them are intertwined that result in the loss of melanocytes. Repigmentation of vitiligo macules involve melanocyte proliferation and their migration, in addition to removal of those causative agents which destroy melanocytes. Irrespective of any mechanism for the loss of melanocytes in the skin leading to vitiligo, their replenishment must involve, as Professor Pandya mentioned, the third pillar, which I emphasize more and more, involve the multiplication of melanocytes and their migration to vitiligo macules for repigmentation to occur. It was observed that many therapies like PUVA, NBUV, and lasers used for treating vitiligo were shown to increase melanocyte growth factors that increase the melanocyte proliferation and their migration to repigment vitiligo macules, in addition to decreasing the autoimmune responses. Therefore, external application of melanocyte growth factors in combination with the above therapies may enhance repigmentation of vitiligo macules. And this is my major emphasis is, no matter what therapies you use to reduce the immune responses or other negative factors, please also include at the same time a growth factor for melanocytes to proliferate and to migrate. That is my major emphasis in my presentation. And we have demonstrated various therapies with decapeptide or this related factor that I am talking about, either with the PUVA, NBUV, tacrolimus, and other modalities like steroids. They all get synergistically stimulate the proliferation of melanocytes and the loss of the repigmentation. And that is what is mentioned. Same way, I believe, actually, Professor Pandya has already mentioned that the rheumatoid arthritis, the drugs used for rheumatoid arthritis also may get better result in combination with growth factors like exposure to sun or NBUV. Therefore, my emphasis will be, if you use these tofacitinib or other drugs in combination with the NBUV and this peptide, I am very confident that it will produce faster result. Now, this is something published long ago, how the melanocytes look from the normal individuals far away from the vitiligo patch and perilesional melanocytes. Now, we have studied the growth characteristics of these melanocytes from normal individuals, vitiligo individuals, perilesional and far away from the lesion. And you can see the number of things here. And also we studied after poor therapy, when they get repigmentation, the patients were very volunteering to give us those melanocytes, and we checked how they proliferate. They proliferate much faster, much better than even normal ones. And you can see those numbers, and I don't need to repeat all of them. Therefore, we ask the question, what is it that poor treatment is doing to the melanocytes to grow so well? So we have taken the serum from those patients who are getting the repigmentation successfully and substituted for fetal cough serum or normal human being serum or from serum from vitiligo patients. And that is, the results are indicated here. Serum from actively repigmenting human vitiligo subjects had maximum mitolinic effect on the growth of melanocytes in culture, followed by the serum from normal donors and from untreated vitiligo subjects in that order. Previous ideas were that poor repigments vitiligo macules by decreasing the autoantibodies to melanocytes in blood circulation and thus help in the repigmentation. At that time, there was no evidence, but we hypothesized that poor therapy resulted also perhaps in the increase of melanocyte growth factors in the serum of patients successfully treated with PUA,
Sir, will you please
and
give
thus
us
correct the defects in the growth of melanocytes in untreated vitiligo patients.
Sir, we can have only time for 2 slides.
Macules. The above hypothesis was shown to be true much later, almost 10 years after, that indeed it happens. The above idea led to the development of this related decapeptide to treat vitiligo. After various phases of clinical trials and prior animal experiments and their approval by the Drug Controller General of India, it was approved as a decapeptide to treat vitiligo in India and marketed in India since 2004 by various brand names.
Yes, Dr. Ramaiah, please, we are almost out of time, so you can have only 3 slides.
I'm sorry?
Yes, we are out of time, so you can have only 3 slides more.
I'm a little deaf.
Yes, you have only 3 slides more because we are out of time.
Yes, out of time.
All right,
so
yes,
I'm sorry,
yes,
I'm
all right, I'm sure,
talking too
all
much,
right,
I
okay.
think. I will go forward. So the take-home lesson and conclusion are the following. Any treatment, as I mentioned earlier, combination with factors which reproduce melanocytes and migrate must be included. And anything which is working for reducing antibodies should be combined with the growth factors. And take-home lesson and acknowledgement I like to make. There are a lot of people who paid for this research, and that's all listed. I don't have to spend time on that. And many people have contributed to the supervision of these clinical trials, because I'm not a clinician. Thank you very much.
Thank you.
I'm sorry.